Every 1 in 2 diabetic patients suffer from peripheral neuropathy or nerve damages in their lifetime. The tingling, numbness, or burning sensations your patients experience significantly impact their quality of life and may lead to severe complications such as foot amputation. Neurotropic B vitamins such as B1, B6, and B12 work synergistically to regenerate the nerve and repair its function. Pharmacy professionals play important roles in detecting early nerve damages and providing timely treatment.
Diabetes mellitus is a prevalent condition that just keeps on rising and rising. If current trends continue, there will be 700 million adults worldwide with type 2 diabetes by 2045.
Up to 50% of diabetic patients are at risk for developing peripheral neuropathy, significantly affecting their quality of life and potentially result in amputation.
Join us this November as we celebrate World Diabetes Day and discuss how you can make a difference in peripheral neuropathy care for your patients. Put life back in your patient's hands.
One touch can bring back the will to live. One smile can spread cheer. One nudge can be someone's strength. Because healthcare is human care, and it does not limit itself to just medicines. It is about understanding pain before painkillers, temperaments before treatments, and the person before the patient. This is made possible by a science far superior than any other. A science that goes beyond treating illness to creating a world of care and wellness. The science of human care. We know. Because this understanding is the core of our innovations and the crux of our legacy. It gives meaning to our medicine. It inspires us to create world-trusted, highly recommended, irresistibly superior quality products that help empower patients and consumers live healthier and more vibrant lives. Healthcare with human care. PNG Health, the science of human care.
All right. Welcome everyone from Malaysia and Philippines, our pharmacists from Malaysia and Philippines. But before anything else, let me just remind you of our house rules. Our webinar house rules. First one, please mute your microphones when entering the meeting. Please place your questions in the Q&A chat box, and I will gladly raise your questions right after all the speakers' lectures. And you have to attend at least 80% of the webinar or the full webinar and are required to fill out an evaluation form in order for you to claim a certificate. Now, how would you claim your certificate? You need to attend the webinar for a minimum of 2 hours to get a certificate because your time here is recorded. You are also required to answer a feedback form at the end of the webinar. The link is available on the chat box and the SwipeRx app. Then, SwipeRx will send you an email with a link and instructions on how to download your certificates once we receive the CPD approval from the Philippines and MPS in Malaysia. For any questions or concerns, please feel free to reach out to us at hello@swiperxapp.com. All right. So once again, welcome to another webinar series provided by SwipeRx, Procter & Gamble Health, and the International Diabetes Federation. As part of our celebration for World Diabetes Day, We are very fortunate to have invited lecturers to talk about a timely and relevant topic on the roles of pharmacists in protecting patients' nerves against neuropathy. This webinar will cover topics on the prevalence and burden of diabetic complications, as well as the screening and management of peripheral neuropathy. We will also have a chance to see cases, and we will invite our lecturers to share their thoughts about those. And after all of those, we will have the synthesis. Now, I know everyone is very excited all throughout Southeast Asia, the pharmacists from Southeast Asia, and I will be very excited to introduce our first lecture for this webinar. Our first speaker is a Malaysian registered pharmacist. He finished his bachelor's degree and master's degree at the University Kebangsaan Malaysia in 2003 and 2010, respectively, and his doctorate degree at the University of Malaya in 2020, which he was a full scholar for all degrees given by Beasiswa Hadiah Latihan Persekutuan Kementerian Kesihatan Malaysia. He is also a certified NTAC diabetes pharmacist of the Pharmaceutical Services Division of the Malaysian Ministry of Health. He was awarded on his excellent service by the Jabatan Kesihatan Wilayah Persekutuan Kuala Lumpur and Putrajaya in 2020. He is currently the head of pharmacy services and an endocrine pharmacist since the start of the year at Hospital Putrajaya. He has been the chairman of the Clinical Pharmacy Working Committee, Endocrine Pharmacy Diabetes Mellitus since 2018 in the Pharmaceutical Services Division of the Malaysian Ministry of Health. He is also the chairman of the Diabetes Medication Therapy Adherence Clinic Committee of the Federal Territory Health Department since 2018. Since 2021, he is the advisor for Practice Transformation Program for Diabetes of the International Pharmaceutical Federation. His research interests and publications focuses on diabetes management and pharmacology, which are presented locally and internationally. Let us all welcome and give a virtual round of applause to Dr. Navin Kumar Loganadan. Take it away, Doc.
Thank you, Mr. Mikey Mendoza, and welcome to everyone. Welcome to the pharmacists from Malaysia and Philippines for joining us today. And this is a very interesting session. We are talking about peripheral neuropathy and how pharmacists can actually, contribute in actually managing this condition. So I'll be sharing today about prevalence and burden of diabetes complications. Let me share my slide. Okay. Okay. So before we talk about any complications, we need to know about the diabetes burden itself. It's actually a very pressing burden globally. It's a global healthcare burden, and if you look at this is actually a diabetes atlas. It's a diabetes atlas. So this diabetes atlas is published by the International Diabetes Federation. You can see that they've divided the globe to different regions, and our area, I think our Southeast Asian nations like Philippines, Malaysia, Thailand, Singapore, we are all together, lumped together with Australia, China, Japan in this Western Pacific region. And interestingly, if you can see the whole picture here, the largest number of diabetes patients in the world reside in the Western Pacific region, which is our region. So in 2019 alone, there were 163 million diabetes patients in the world, in this region, Western Pacific region, and this is projected to increase by 31% to 197 million in 2030, and also reach 212 million by 2045. Yeah. So if this current trend continues, it is expected that there will be 700 million adults who will have diabetes in the world by 2045. Yeah. So this increase in burden definitely has an impact on the country's economic system, okay, or the healthcare system, puts a pressure to the healthcare system in the country. So if you can see that in this figure, the expenditure, the diabetes related health expenditure, how much is being spent on diabetes, not just treating diabetes disease, but also its complications. This figure has increased from 2019, expected to increase from 2019 to 2030 to 2045. And currently, this whole diabetes expenditure takes about 10% of the global health expenditure. So that is actually quite a lot, 1/10 of the money spent on health, because we have other diseases like, cancer or respiratory diseases, infectious diseases and all that. There's so many diseases, yet 10%, which is, quite a lot being spent on this diabetes. So it's the time to actually, for us to actually look at how we want to actually reduce this figure and also control the spread of diabetes pandemic. Yeah. So usually patients do not, once they're diagnosed with diabetes, they do not actually just die the next day, or they have the complications the next day, because these diabetes related complications can occur slowly and steadily, sometimes without any clues to the patient that they are happening, depending on whether the patient has enough diabetes knowledge or not. If not, they might not know that these complications are already setting in. Yeah. So usually the important, the main debilitating factor is actually the complications, not just the diabetes itself, because a lot of patients die due to diabetes complications. Only very few of patients die on acute complications of diabetes, like severe high glucose, which can result in diabetic ketoacidosis, or hyperglycemic hyperosmolar symptoms, which can be treated in the ICU. And usually with enough insulin treatment and quick insulin treatment, we can actually bring down and stabilize the patient. But these chronic conditions occur very slowly. Okay, so let's look at it. Okay, what are the complications? Okay, usually when you have high blood glucose, the high blood glucose can turn into a toxin. We call this as glucotoxicity, meaning the glucose in excess now turns as a toxin, and it starts to attack the pancreas and further reduce the pancreas function, making the patient further difficult to control diabetes, because the insulin amount is actually reduced. So when on the other hand, when the patients are actually having persistently high glucose, then it will actually damage the inner walls of the blood vessels. That's why it attacks the blood vessels. You see a lot of all these complications are actually related to vessels. So if they are related with major or big vessels, we call that as macrovascular complications. If they're related with small vessels, we call them as microvascular complications. So in this case, you see, it attacks the bigger vessel that supplies the blood to the brain. If this supply is disrupted, then it can result in a stroke, which is about 6.66% in our patients with diabetes. And if it attacks the small blood vessel, which supplies the blood to the eyes, then the patient can have retinopathy. Retinopathy, it also has the early stage, which is non-proliferative. Then we also have proliferative retinopathy, which is can lead to blindness as well. So it is something to be taken seriously. And this figure, the figure is about 35% of patients will have this complication. And another one that usually everybody is scared about is actually the cardiac complications. The cardiovascular disease happens because the damages happen to the big blood vessels, the macro vessels, okay, the coronary artery that supplies the blood to the heart. And this occurs in 32% of the patients. You can have it as, in the early stage as an angina, or even a serious one, such as a massive myocardial infarction that can lead to death. Okay, and also this is another complications, microvascular complications, that's very famous, which is nephropathy. And this chronic kidney disease can actually progress into end-stage kidney failure, resulting in dialysis and also death in patients. This occur in 25 to 36% of patients. Another one, which is also interesting as what we're talking today, is peripheral neuropathy. It is damages to the nerves that happen due to persistently high blood glucose, and this can lead to diabetic foot syndrome, which usually when a patient is diabetic, they also have peripheral vascular disease. They have very poor circulation of blood to the peripheries, and feet is something an organ that's very far away from the heart, and it takes a very long time for the blood to reach to the feet. Poor circulation combined with peripheral neuropathy, sometimes patient can have non-healing ulcers, which would lead to the need to actually amputate their legs. Okay, amputate their below knee amputation or even above knee amputation. So they'll result in loss of limbs. Okay, and these risk factors for complications include if the patient is smoking, if they're overweight and obese, if the patient is always not exercising, physically inactive, and if they have blood pressure and cholesterol that's not controlled within the target, they can easily or quickly progress to these complications. So early diagnosis, lifestyle changes, consistent treatment, and patient compliance, all these are the keys to avoid disabling and life-threatening complications that we have discussed just now. So today, from those complications, we will narrow down the scope to diabetes and peripheral neuropathy. And what we are going to talk today is about the nerve system, and we look at the damages and that can happen there. So when you talk about the nervous system, it's divided into central nervous system, CNS, that is divided into the brain and spinal cord. And you also have the peripheral nervous system, which, there are nerves that connect the brain to every other part of the body. That's very important, to all the areas. So all our physical functions daily, the movements and all that is dependent on all this nerve conduction or the signals from the brain. If you are lifting your hand, you are actually walking, or lifting your arm, or doing anything. So all these actually really need the signals from the brain. So the transmission of nerve signals, if it's within the cells, it is conveyed along the cell membrane. But if, let's say, there is actually a transmission between the cells, these electrical signals are converted to chemical signals, and they're conveyed via neurotransmitters. So you can see here, this is actually a nerve cell. So it is made of a bundle of neurons, also called a nerve cell, and the neurons are the fundamental and functional units of the nerve system. So I would like to attract your attention to that light blue in the diagram, the shaded light blue shade in the diagram. This refers to the myelin sheath. So then there is this myelin sheath that's covering the nerve fiber that you're actually seeing there, right? So let's go further on that. So if you, I'm very sure all of you are familiar with the cable, wires, electrical wires. You use definitely this electrical wires or cables to actually charge your phone. And you know that the real actual wire is actually not seen from the outside. It is actually covered by an insulating rubber, or polymer. It's covered from the outside, so that the real electrical wires actually, they are not seen from the outside. So similarly, in the nerve cells, the myelin sheath provides the protection and insulation, and also helps the nerve signals travel along the way, right? And what happens if this myelin sheath or the protective layer is damaged? Then the nerve can be damaged as well, and the electrical signal can be disrupted. So when the electrical signal is disrupted, then the command from the brain does not go to the organs, and you will have disability in terms of carrying out the functions, the basic functions. Again, this is just a recap. It's just showing where the damages can happen. If you can see somewhere in the center, you see the orangey area, there are some areas where the myelin sheath is actually damaged, or the layer is removed. So then the nerve fibers are exposed to the outside. So when you're exposed, then it can result in peripheral neuropathy and also a lot of pain. So let's look at how when does the peripheral neuropathy develop? Okay, it can actually start developing when the the nerve cells become damaged. And here on the left side you have a healthy patient, and who probably is not diagnosed yet with peripheral neuropathy, but they can be asymptomatic in the beginning, but the nerves can already be damaged. They may already have damage of the nerves, but then they are not showing any symptoms, and or they might have just mild symptoms. So as they progress, assuming that no treatment is given to this patient, then they will progress to go on to moderate peripheral neuropathy. They will already start to manifest some symptoms. We will look at the symptoms after this. And if, let's say, no treatment is given or no attention is given, then this moderate peripheral neuropathy will actually worsen and progress to the advanced stage. And usually patients with severe peripheral neuropathy will start feeling pain. Neuropathic pain is the manifestation of manifestation of severe peripheral neuropathy, and it's usually very difficult to treat when they already come to this stage, because they'll have pain. And then we need to use a lot of painkillers to treat them, to numb the pain, because neuropathic pain can be very painful. Okay, it can occur throughout the day, not just at night. It can also occur during the day, especially if the patients are working, or even, if they're not working, they're staying at home and doing other daily chores. It can really disrupt their quality of life. So let's look at the symptoms here. The symptoms of peripheral neuropathy can vary from patient to patients and can have serious long-term consequences. One of the symptoms that very commonly patient report at probably the early or moderate stage is actually tingling and numbness. So if you want to describe tingling, it's something like feeling of ants crawling on their feet. Suddenly you have some ants crawling on their feet. How does it feel? That's how they describe. We have to use this description. It's not very clear cut. If you say just tingling, the patient may not actually be able to relate. So you have to ask for description. What does it feel? Okay, or probably if, let's say, the patients have sat down somewhere, or they've just folded their legs for some yoga, or probably they're just sitting down on the floor and having the meal, and just chit-chatting with their friends at 30 minutes or about 1 hour, they want to get up. Suddenly they feel numb. They feel that my feet is already dead. I feel that it's already dead. I don't feel anything. I can't unfold my legs. Can you please help me? Can you just, I can't get up, so there is numbness. So what also happens is that these are all the early signs that, if often overlooked, it can result in serious consequences. Let's say the patients actually lose their senses, continue to lose their senses, then they may not notice any injuries. So let's say if they have a small cut, a minor cut, if they have actually stepped on a glass or a nail or some sharp objects, then they may not notice it because they don't have the senses. So because they have neuropathy, they don't have the feeling. They don't realize that there is an object that actually has caused a cut, and then they need to remove them. Unlike you or me, okay, the healthy people, once they have stepped on something sharp, they will immediately have the reaction that they will actually, look down and try to remove the stone or whatever sharp objects that they have actually, that has pricked their legs or their feet. Okay, so what happens if, let's say, they do not notice these injuries? Let's say they do not do regular foot check, foot examination, so they are not very sure that they have wounds. So let's say it goes on for a few days, 1 week or 1 week plus, it can start to grow as a big ulcer. And from this ulcer, it can progress into a deep ulcer that is very difficult to heal. Sometimes it need wound cares, months of wound care sessions to actually heal that wound. It's going to be very difficult. Also, because patients with diabetes can also have poor blood circulation, making the wound healing even more difficult. And sometimes, if, let's say, that ulcer grows very significantly and become infected, then maybe the limb need to be amputated. The legs need to be amputated. Okay, so we also have patients reporting allodynia. Allodynia is another side. It's like quite severe peripheral neuropathy when patient even hit the bed and they start to actually lie down on the bed. The bed sheet itself feels very painful when they rub their body or their back on a bed sheet. It also feels that's very painful. You know, can you imagine someone, you know, hitting the bed and they can't even really lie down on the bed because it feels very painful. So it's actually severe neuropathy, and these patients, even if you touch them, a light touch, then they feel very painful. And usually these symptoms can be very severe at night. Usually neuropathy symptoms like, you know, burning sensations can occur at night and disturb patient's sleep. So what are the causes of peripheral nerve damage? Of course, the main cause here, more than 34%, 35% of patients actually, people with diabetes actually have peripheral damage. Of course, a lot of other patients, like 22% of patients actually do not have clear etiology. A smaller percentage of patients with who takes alcohol or Guillain-Barré syndromes and infections do have this peripheral nerve damage. If you look at the risk factors, increasing age or being in the elderly group is definitely a risk factor, because you can see here, compared to patients in the 40 plus category, those who are 60 plus or 70 plus or 80 years or older definitely has higher risk. Also, this is age related, with or without diabetes. You can see this figure, if they are having diabetes or not. Even increasing age is already a risk factor for peripheral neuropathy, and if they have diabetes, it's actually even worse. All right, they will get it faster. So you can say that in this study, about 490 patients with 19 patients with diabetes, 14.8% of them actually have peripheral neuropathy. Okay, and in terms of gender, men actually has a slightly higher risk compared to women. And in terms of race, this is actually a United States study. You can see that black race actually has higher risk of neuropathy compared to whites and also Mexicans. Yeah. So this is a local study from Malaysia, peripheral neuropathy among elderly diabetes patients in a tertiary center. You can see they studied almost 300 diabetes patients who are elderly, the average age about 67 years old. They're long-standing diabetes patients with diabetes duration of almost 10 years, and they actually have a prevalence of peripheral neuropathy of 51%, which means that 1 in 2 or half of those elderly patients actually, diabetes patients, report peripheral neuropathy. And this can be detected through physical examination and monofilament tests. And this is another systematic review. This is showing patients who are, pre-diabetes patients, not even diabetic, they are pre-diabetes patients. So these are studies that reported pre-diabetes patients' peripheral neuropathy, and you can see the prevalence ranges from 2 to 77%. Majority of the study reported at least more than 10% prevalence, and then the higher prevalence among the studies evaluating small nerve fibers that we're talking about. And also one important thing that they have shown here is pre-diabetes is a risk factor for chronic axonal polyneuropathy. What does this show is that even before they are diagnosed, they are not safe, because they already start having the damages of the nerve cells in their body before they are even diagnosed as diabetes, right? So here I would like to show how bad this peripheral neuropathy can get for these patients, because we are here talking about very, scary complications like myocardial infarction, death, and also end-stage renal failure and dialysis and all that. But often people do not talk so much about peripheral neuropathy, because maybe it's always mistaken as something that's manageable. But untreated diabetic peripheral neuropathy can result in painful diabetic peripheral neuropathy. I've seen quite a lot of patients with painful diabetic peripheral neuropathy. So it's very difficult for them. They're every day, they live with this pain. So they have this pain every day. And then if you look at this study, it interferes with their enjoyment of life, their mobility, their normal work, and also their sleep. You can see the scores actually are very low, almost just 57%. And more importantly, you can see that the lower part of the table, it affects the relation with other people. I think with this painful diabetic peripheral neuropathy, the patients do not want to socialize, they do not want to go out to see people, they also do not want to perform self-care, and it is even more compounding the diabetes management because, you know, when they don't really have self-care, then the diabetes management is going to be poor, right? And peripheral neuropathy can lead to all these conditions that affect quality of life and also social life. One of it is depression. It's the most common comorbidity with prevalence rates approaching 100%. And depression can be both the cause and result of sleep disturbances as well. So sleep disturbances, patients report difficulties in sleeping after initial onset of pain, and of aspects such as hours of sleep, number of awakenings, and time awake after sleep are all adversely affected in patients with chronic pain, chronic neuropathic pain. And another thing is that anxiety, it really can happen to these patients with peripheral neuropathy. They can have mood disturbances apart from the poor sleep that they're having. So in summary, what I would like to tell you is that, you know, the burden of peripheral neuropathy is enormous due to its high prevalence. We have seen from this data that 1 in 2 diabetes patients have peripheral neuropathy, and also non-diabetic patients, they have higher risk, especially if, let's say, they are elderly, they are at higher risk. And if they are males, you have higher risk of peripheral neuropathy. And diabetes is definitely one of the major risk factor and etiology for painful diabetic peripheral neuropathy. And what we need to do is we need to identify the patients with early onset peripheral neuropathy, but this is often challenging because, you know, it depends on patients' diabetes knowledge. If they're able to recognize the symptoms, then they will be able to report to us the symptoms. If they themselves are not aware of these symptoms, that such symptoms are symptoms of neuropathy, then they are not going to report to you as pharmacists, and then they're going to live with that probably for a few years until something serious happens, like ulcer, like an unhealing ulcer or an amputation. So that is actually quite sad to wait until then. So peripheral neuropathy leads to severe complications and impaired quality of life. I've mentioned to you, it's very difficult. If we want to control diabetes very well, we want to prolong life. But at the same time, if we don't address this neuropathy, then they are going to live a long life, especially in the older age, where a lot of them actually lack support, family support. And if you have complications like this, that's really making them troublesome to sleep and also do their work and day-to-day chores, it's going to be very difficult. And finally, treatment need to be started as early as possible to prevent these complications. We need to address this early. Actually, we can help patients to prevent this complication from happening. But for that, we need to be very well educated on what to do and what are the treatments. This will be shared by the next speakers in this session. So with that, I pass back to the MC. Thank you very much.
All right, thank you very much, Dr. Navin. But for the meantime, let's ask our participants for a short poll, okay? So we'll run the poll. Okay.
Okay. Do you want me to run the poll?
Yes, doctor.
Okay. Yes. Done. Okay. Yes. Done. Okay. Please answer the questions of the diabetes patients you have seen in the past 3 months. What percentage of diabetes patients suffer from diabetic peripheral neuropathy, such as tingling, numbness, or burning sensations? Is it A, less than or equivalent to 10%, B, 10 to 30%, C, 30 to 50%, D, 50 to 70%, and E, more than 70%? We will wait for you probably a minute or two for most of you to answer, and after that we will see what's your response. Okay. So majority of you actually have selected 30 to 50%, which is actually corresponding to the real surveys, the real studies that's been published, because just now from the studies that are published, I mean, that I've shared just now, shown that the prevalence is about 51%, 50%. So you are right, about 1 in 2 diabetes patients actually suffer from peripheral neuropathy. So so I guess I think this feedback is very important. So that shows that there are a lot of things that you pharmacists can do, and please learn from the subsequent speakers so that you know how to manage diabetes patients. And we also have 2 cases at the end to help you to actually manage patients with this condition. Thank you.
All right. Thank you very much, Dr. Navin, for explaining the impact of diabetes to the community, as well as the burden of peripheral neuropathy to the quality of lives of our patients. So thank you very much again to our participants who answered our poll question. Okay, I know you're very excited to meet our next speaker. So let me just introduce him. Let me introduce our second lecturer for today. Our next speaker is a Filipino registered pharmacist and entrepreneur. He finished his bachelor's degree in pharmacy, major in clinical pharmacy, his master's degree as well in pharmacy, and PhD in education, major in educational leadership at University of Immaculate Conception, Davao City, Philippines in 2014, 2013, and 2018. He is currently finishing his second doctorate degree in management at Lyceum of the Philippines University since 2020. He is the manager and proprietor of Merin Pharmacy and the president of the Philippine Pharmacists Association Davao City chapter. He is also a Filipino certified immunizing pharmacist, as well as a national certificate repasser for pharmacy services by the Technical Education and Skills Development Authority in the Philippines. Currently, he serves as the Dean of the College of Health and Sciences and the Program Chair for Pharmacy at Lyceum of the Philippines University, Davao City. He is active in his mother organization, the Philippine Pharmacists Association, where he was awarded as the 2020 Outstanding Community Pharmacist. He was also the first recipient of the Ideal Young Pharmacist Awards by the Young Pharmacist Group Philippines. He actively participates in organizing free patient care on his drugstore, Merin Pharmacy. He also published several research articles focusing on areas of phytochemistry, medication adherence, and supply system management. Let us give a virtual round of applause to Dr. Kenny James Merin. Take it away, Doc.
And of course, good afternoon to everyone here in the Zoom room, meeting you all virtually. Thank you so much for spending your time with us this Saturday afternoon. So I'm here tasked to talk to you about how pharmacists can protect the patient's nerves against neuropathy. Specifically, I'll be talking to you about screening of peripheral neuropathy. Who is at risk? Well, as Dr. Navin said earlier, in the cases of peripheral neuropathy, the earlier we get to it, the better. The longer we wait for this neuropathy to eat up and to damage our nerves, it will really go unchecked, and a lot of complications will arise from it. If we catch it early, we prevent further progression and we prevent development of comorbidities. It was also mentioned that there is sleep deprivation, chronic pain that can lead to depression and anxiety, which is now a triad: chronic pain, sleep disturbances, and depression and anxiety. A lot of patients do not really notice it from the beginning. You know, it's just a tingling sensation. Sometimes it's just very minute that we give it attention to. They are really not that much disturbed. Some are just, when they sleep it off, it's already okay. They don't see it as something that is serious. And especially true here in the Philippines, a lot of people are afraid to know what their sickness are. So they just ignore it. They just make a reason for it. However, peripheral neuropathy is also often undiagnosed with physicians. There's a struggle to diagnose peripheral neuropathy because the time that we have for each patient and the doctor is very limited. We all know that when we go to a doctor, we wait long lines, and then when we talk to the doctor, we only have a few minutes that is given because there's a lot of patients waiting. Physicians sometimes would think that there is a need for complicated devices to diagnose neuropathy. But however, there are some supplemental tools which pharmacists can use in order for us to aid in this diagnosis of peripheral neuropathy. You know how important your role is as pharmacists, specifically those that are working in the community. You are the most accessible people in the healthcare system, and we are ones of those that can really help identify the initial symptoms, the early symptoms of peripheral neuropathy, and guide these patients towards having their follow-up checkup so that they can have it addressed and, of course, diagnosed and treated. Now, this is a simple tool where we can evaluate your patient's condition. May I know from the chat box from our participants, how many here are working in the community pharmacy? Can you just hit me in the webinar chat? Just tell me if you are working in the community. I'd like to see how many of us here are working in the community pharmacy, because I'd like you to appreciate your role. Currently, in the data that is presented by Dr. Navin and all of our discussions and reading, there's a gray area where pharmacists can fill in. What I'm trying to say is, patients are in the middle of a crisis where peripheral neuropathy is happening, yet doctors underdiagnose it and patients undermine it. In the middle, there is the pharmacist, who is one of the most accessible. And with our help in identifying the risks, identifying the possible risk factors, we can help patients, direct patients towards the needed medical attention. Now, how are we going to check for that? We abbreviate it with condition. These are those that are at high risk for developing peripheral neuropathy. First, you check the groups that are most at risk for peripheral neuropathy. Of course, we know people with organ dysfunction are at high risk for peripheral neuropathy. First and foremost, the one that we are celebrating, the awareness of diabetes mellitus, which happens on Monday. Diabetes mellitus damages our nerve cells because of the increase in blood sugar. A lot of these cases are mostly found on the legs and feet. So as community pharmacists, we can actually help. We can actually ask. We can actually be curious with our patients. We ask them, if you know that they are diabetic patients, you ask them, how are you feeling? Do you experience any tingling sensation on your hands and feet? Because that's the start. And when they have it, we can recommend vitamin supplementation. And of course, most importantly, we refer to the physician in order for them to get that medical attention. Second, there's renal impairment. Because of the decrease of level of electrolytes, it negatively affects the health of our nerve cells. And of course, there's an increase of toxins because of the inability of our kidney to filter the blood. The increase in the toxins can also affect the integrity of these nerve cells. Hypothyroidism, because of the fluid retention, there is pressing of the nerve cells, causing the peripheral nerves, causing pain, and the liver impairment, same, especially common in the end stage. There's a toxin buildup due to inability for the liver to filter. Now, what's most important here? Where do community pharmacists stand? There is a very, very unique knowledge for community pharmacists when we talk to our clients and even just receiving their prescription. Seeing the list of medicines that they buy, you are already having that knowledge if they are diabetic, if they have renal impairment, if they are suffering from hypothyroidism, or if they have liver impairment. That knowledge can actually be used to help them identify and screen for peripheral neuropathy. If you have patients that are with any of these organ dysfunction, then you also have to screen. This is our role now. We have to help them because, again, as mentioned, a lot of our patients just disregard the symptoms, and when they grow from time, it progresses and it becomes more problematic. And most importantly, we should understand, dear pharmacists, that the longer it happens, the peripheral neuropathy, the damage that it happens in the nerve cells, it becomes irreversible. And that is a point where we cannot help our patients anymore. So it is very important and vital that we do our role in the screening, especially when it's still in an early stage. Now, how do we do that? Again, look at the organ dysfunctions. If you look at the medications and you identify your patients with organ dysfunctions, talk to them, ask them about questions that may give you a hint if they are at risk for peripheral neuropathy or experiencing the initials of peripheral neuropathy, and lead them towards medical care. Next is nutritional deficiency. Of course, there's advanced age, specifically those that are 65 above. I believe Dr. Navin was able to show us earlier a graph where the incidence of peripheral neuropathy increases as our age increases. This is because of the axonal damage, or what we call the demyelination. There is also the GI disorder that is attributed to our B12 deficiency and vegetarianism, when it's hard to source from vegetables, specifically our vitamin B12, because this is commonly seen in meat, seafood, and dairy products. And then there is also fasting because of the vitamin B12 deficiency. This nutritional deficiency is still part of the role of pharmacists. Specifically in the community, when we do our counseling, we do not just focus on medicines. There are non-pharmacologic interaction, which includes diet. Now, if you see people suffering from peripheral neuropathy or is at risk for peripheral neuropathy, then it is time to advise them to supplement with vitamins. For example, for if you know that they are vegetarian, then it is good that we advise that you should be drinking vitamin B12 in order for you not to suffer from any B12 deficiency, and of course suffer from peripheral neuropathy. Those with advanced age, you can actually recommend those vitamins, of course coordinating with their doctor, and those with GI disorders that will also be mentioned, that was also mentioned. Next, let's go to the pharmacologic, the drug-induced neuropathy, something that every pharmacist should be mindful of, because this is the heart of our profession. We now see that drugs like metformin, isoniazid, and chemotherapy can actually cause peripheral neuropathy. Metformin is the first line of treatment for diabetes mellitus, and now the long-term use of metformin actually causes the low level of cobalamin, or our vitamin B12. It also causes an increase in methylmalonic acid and homocysteine levels, causing diabetic peripheral neuropathy. So therefore, there is a need for us to screen those people that are using metformin. I can only speak for the Philippines, and the practice here is that when you have your maintenance, a lot of people think that the maintenance medication is forever. They keep on drinking it, they keep on using it, and we are not fond of follow-up checkups. This is the role of the pharmacist here in the community in the Philippines, where we have to advocate follow-up checkups, because metformin use for more than 18 months can actually increase the risk of peripheral neuropathy. Therefore, there is a need to shift to another medication or to supplement with vitamin B12, all of which can only be done if we have coordination with the doctor and, of course, referral. There is also the isoniazid, which inhibits specifically our pyridoxine phosphokinase, and it causes functional pyridoxine deficiency, which induces peripheral neuropathy. So for people that are taking isoniazid, there should also be our identifier of the peripheral neuropathy, because the risk is high. Chemotherapy, of course, there's what we call the chemotherapy-induced peripheral neuropathy, because the chemotherapy can damage our peripheral nerves. So there's a way to prevent it. The supplementation of vitamin B12 can help. Therefore, as pharmacists, those that are working in the hospital, that are clinical pharmacists, it is also a good recommendation, not just to be reactive to what the patient is experiencing, but become proactive on the possibility of development of peripheral neuropathy. How can you help in the prevention, in the lowering of the risk of developing peripheral neuropathy, and managing it even before it becomes evident? Those are our roles in drug-induced neuropathy. And then there comes our toxins, because of the axonal degeneration. Specifically, the example here is chronic alcoholism. So alcohol damages our peripheral nerves and leads to decreased levels of vitamin B12. This also disrupts our ability to acquire nutrients in the nerves. That's why it causes peripheral neuropathy. So I think that's also part, if we have patients that are at risk for peripheral neuropathy, diabetic patients, then automatically this is now a concern for us, where we have to advise them that alcoholism or alcohol should be avoided so that they do not develop or worsen their peripheral neuropathy. There are also cases of infection. Specifically, we have here the HIV, which infects our glia. We know it supports and protects our neurons. Tuberculosis is arguably an immune-mediated and sometimes a direct invasion to the nerves, and leprosy, which has sensory nerve damage, and the sensory nerve damage registers as pain. These three examples of infections, if they come to the pharmacy and then we know they're infections, then it is also our responsibility to tag them as high risk for peripheral neuropathy, discuss it with the doctor, do referrals, and speak with the doctors in order for us to avoid future problems with peripheral neuropathy. There are other causes of peripheral neuropathy, namely the critical illness polyneuropathy, entrapment neuropathy, idiopathic neuropathy. So I hope pharmacists across all practices are able to identify patients that are at high risk. Please take note of the diseases, nutritional deficiency, the drugs, the toxins, and infections that you can use during your patient counseling, during your medication counseling, during your patient profiling, in order for us to help patients that are at risk or are experiencing peripheral neuropathy. Peripheral neuropathy can be caused by a multitude of conditions. So upon those that we have talked about, multiple cases can be the cause, but let's take note that the leading cause of neuropathy is actually your diabetes mellitus, both the disease and one of its treatments, specifically the metformin. Metformin use is associated with worsening of diabetic polyneuropathy. So there's also a need for us pharmacists to discuss with physicians when there is evident neuropathy, peripheral neuropathy, especially if it is already disabilitating, then we have to recommend the shifting of medications from metformin to another form of anti-diabetic that will decrease the incidence of peripheral neuropathy, and of course, help our patients from the suffering that they are experiencing with peripheral neuropathy. We all know that metformin is the first-line therapy. However, we must take note that patients aged 50 and above, and those that use metformin for more than a year and a half, are 2 to 3 times more likely to develop peripheral neuropathy. This is something that is a note, good to note, so that when we are in practice, we can recommend to doctors when we talk to them that metformin may not be a good choice for patients above 50 years old. And when it is already a year and a half, we really have to watch out for peripheral neuropathy. And when they start to develop, so that it will not worsen, we have to consider another form of therapy so that the peripheral neuropathy will not worsen. Prolonged use and higher doses of metformin can also lead to vitamin B12 deficiency, as what we have mentioned earlier. So for every diabetic patient filling their metformin prescription at your pharmacy, it is your moral obligation, pharmacist, to do screening for them for peripheral neuropathy because the risk is high. This is the gray area that I was talking about earlier. How do you contribute to the community aside from just dispensing medication? We have to keep our patients healthy. We have to avoid complications, and we have to help them in managing their diseases and its comorbidities like peripheral neuropathy for diabetes mellitus. It was also mentioned that the prevalence of peripheral neuropathy increases with age. So therefore, here, when our patients are 70 to 79, 80 and older, there is also a need for pharmacists to really dig in to the peripheral neuropathy screening and help these patients identify if they are just, thinking that, oh, it's because of old age, it's because I have a lot of sickness, it's because I'm already 80 years old, it's normal that I have tingling sensation, numbness, pain, etc. Well, of course, it's not. There are cases, but if it is because of peripheral neuropathy, we can intervene and let them live a better life. That's your role. That's our role in the community. So there is really a need for us to step up the game and really talk to our clients, get to know them, especially those with higher ages, so that we can help them in cases like peripheral neuropathy. Early diagnosis and timely treatment prevents further nerve damage. This is what we want to emphasize. That's why pharmacists are very important. You know, patients would often be seen in our pharmacies, maybe once a week, sometimes once a day, sometimes once a month. That's the least, I think, once a month. And when we try to talk to them and ask them about peripheral neuropathy, the symptoms that we may check, the earlier we catch it, the lesser their chances of developing into an advanced stage with severe symptoms, where 50% of fibers and nerve tissues are already damaged. At this point, pharmacists and doctors can no longer do anything to help them with the pain. Maybe there are pain relievers, but it's already a point of no return for regeneration, potential regeneration. Therefore, in the first two, where there is onset of mild symptoms, that's why you have to screen. And if these symptoms are evident and is still untreated, pharmacists have to catch these patients, right? We have to identify them, we have to screen them, and we really have to push them to have their follow-up checkups with medical doctors so that this condition, the peripheral neuropathy, does not go unaddressed. We have to make sure that they don't go to the point of no return. And how do we do that? We need to actively participate in their treatment regimen. We have to guide them, and we have to let them realize that, hey, what you're experiencing is not normal, and there's a way to help you regenerate your nerves so that they do not progress into so much damage that you will experience pain for the rest of your life. Help your patients avoid permanent nerve damage with early identification of peripheral neuropathy symptoms and timely treatment. Again, I will leave this to all the pharmacists, both in Malaysia and Philippines. We have to help in the early identification of peripheral neuropathy. Now, let's take an easy guide on how do we screen peripheral neuropathy within minutes. There are 5 steps. The first step, you have to classify the symptoms based on the duration of onset. Second, you have to take a careful medical history. Remember, medications can cause peripheral neuropathy. Third, assess signs and symptoms proactively. Number 4, use simple tools to test for nerve function. And number 5, advise patient to seek consultation with physician. We always work with physicians so that our patients will be at the peak of their health. In classifying the symptoms onset, you have to identify if it is acute, subacute, or chronic. How do we know that? When you do your patient profiling, when you do your counseling, you ask how long have they experienced their symptoms? Is it days? Then that's acute. Is it weeks to months? Then that is subacute. Is it more than 6 months? Then that is considered chronic. This information provides an initial differential diagnosis based on symptom duration. Okay? But remember, we are not here to diagnose. This is for us to help identify, screen, if there is a need for them to go to a doctor. We have to establish the urgency, and we have to establish if the progression of the disease is already advanced or not yet, how soon do they need to see their doctor so that they can avoid the complications. Second, take careful medical history. You have to ask the patients, are there any existing medical condition? For example, we mentioned there's a risk for those with hypothyroidism, chronic liver disease, chronic kidney disease, and diabetes. Even those with end-stage liver and kidney disease, we have to identify them. Because if they are present, then it means that the risk for peripheral neuropathy is high. If symptoms are present and then medical condition is present, then automatically that tells us this patient needs medical attention, especially if the peripheral neuropathy is not yet identified and number 2 is not yet treated. If there are contact with toxins like organophosphorus agents, alcohol, arsenic, and mercury, plus the symptoms of peripheral neuropathy, then there's a need to refer them to the emergency room. Next is nutritional deficiency. Does your patient have vitamin B deficiency? Are there malabsorption syndromes, bariatric surgeries in the gastrointestinal tract that would lead to the inability or decreased capacity of your body to absorb vitamin B12 and may lead to nerve damage. Thus, this patient have the following medications currently in use: isoniazid, colchicine, dapsone, amiodarone, nitrofurantoin, metronidazole, ethambutol, and is the patient undergoing chemotherapy. That is already telling us, again, there's a high risk of developing peripheral neuropathy, drug-induced peripheral neuropathy. Therefore, if the symptoms are present plus the medication use, then there's a need to refer or talk to the physician, informing them that there is evidence of peripheral neuropathy and it is unaddressed. For infections, amyloidosis, HIV, hepatitis B or C can also be cause of concern if symptoms of peripheral neuropathy are present. This helps identify patients at high risk for peripheral neuropathy and underlying causes that may contribute to peripheral neuropathy. We can use this knowledge and guide when we talk to clients in order for us to screen, identify, and guide the patients on what steps to take in order for them not to suffer from peripheral neuropathy. Number 4, are we on number 4? Number 3 pa pala, my apologies. Number 3, assess symptoms and signs of peripheral neuropathy proactively. Proactively ask patients about their symptoms. Kanina, underlying cause. A while ago, those were the underlying causes, drug-induced and disease-related that can cause peripheral neuropathy. But you have to tie that up. I've been mentioning this. You have to tie that up with symptoms. So what are the symptoms that you have to ask your patients? Is there a tingling sensation on your extremities? Are there muscle weakness on your hands and feet? Is there a burning sensation on your extremities? Numbness, especially when you are sleeping, or dizziness? These are symptoms that you have to ask, plus the risk factor that is already an area of concern. And of course, that is already an actionable point where we can refer the patient to a physician. Patients may have difficulty expressing their symptoms, so you can use descriptive questions like, do you have feelings as if ants are crawling along your feet? That's the tingling sensation. Does it feel electric shocks, like electric shocks out of nothing, still in the tingling sensation? Does the bedsheet on your feet feel painful sometimes, the burning sensation? Is it worse at night, the numbness when you're sleeping? Does it occur on both sides, symmetrical on your extremities? Where do you experience the pain and sensation? So, you know, as pharmacists, when we collect data, sometimes it's not just as simple as yes and no, or yes or no. You have to be creative, especially for patients who have difficulty in expressing and identifying the symptoms. Sometimes they don't know what tingling sensation is. So you have to describe it in a level that they understand and that they can relate to, so that we can help them identify if these are symptoms of concern and if it is related to peripheral neuropathy. You can also ask your patients to circle symptoms with a simple sketch. So this is something that we can use, we can develop in our pharmacy. We can have this as our counseling aids where we can print it and then we can ask them to fill it out. Fourth, we use simple tools to test for nerve function. There are 4 recommended here that the pharmacist can do with our office supplies. Number 1, there's touch sensitivity. So in order for us to identify if there is really any of those symptoms mentioned in number 3, we can use a cotton wool or tissue where we can run them through the extremities. And then we can ask them if they can feel it the way that we should feel it. We should know, because if we try it on ourselves and then we ask them to describe the feeling, is it the same? Texture perception like a feather, toothpick so that we can apply pressure and pain, and a 2-point discrimination test where we can use a paper clip. Now, if there are diminished light touch, pin, and vibration sensation, this is consistent with a diagnosis of PN. So this is, again, an opportunity for pharmacists to work with physicians. If any of these preliminary tools and tests for nerve functions are present, and then there are the risk factors, and they also mentioned in number 3, the symptoms that they're experiencing, that's already a bullseye for you to do a referral to a physician so that we can help them give focus on peripheral neuropathy and help explain that this is already disturbing our patient's health, attention, and lifestyle. and of course, with the ultimate goal of identifying and treating peripheral neuropathy even before it worsens. Fifth, advise patient to seek consultation with physician. I have been repeating again and again and again. This fight is not for the pharmacist alone. We have to work together with physician to help our clients. For example, it seems that you have an early sign of PN. You cannot say you have peripheral neuropathy. That's the work of doctors. We have to know our boundaries. We have to respect those boundaries so that the respect is mutual. So we have to be careful with our words when we talk to our clients. We have to describe. It seems that you have early signs of PN. I highly recommend that you seek a session with a specialist. It would be good if you already have someone that you can refer to directly. They can conduct further tests to confirm if you really have peripheral neuropathy. Therefore, we are telling that you have to be diagnosed by a physician. So the patients would probably say, I see, I will do. Thank you for your advice. Further examinations, including laboratory tests, can identify or rule out other possible causes of the symptoms and really pin it down to peripheral neuropathy even before we start our treatment. Question: is self-diagnosis possible? You might ask yourself now, is it actually possible to self-diagnose peripheral neuropathy? The clear answer is no. Peripheral neuropathy requires a diagnostic procedure done by a healthcare professional. However, there are ways to increase awareness so that the patient is aware if he or she is at risk and should see a physician. The secret there is to create the urgency to have it checked. Because if there is no urgency and they don't understand what is happening, then they will never get it checked. They will never have it treated, and it will continue to progress. On the next slide, you will see a simple list of possible experiences out of everyday life which can help the patient to check whether he or she is at risk for peripheral neuropathy. This is another counseling aid that we may have. And then you can talk to the clients, you can show it to them, and then you ask them if you have difficulties performing activities such as buttoning your shirt, opening toothpaste tube, opening a bottle of water, then you can check this one. I feel prickling, tingling sensations on my hand and feet, experience pain, I'm wearing invisible gloves or socks. That's what I feel for my hands and feet. Sometimes there's electric shock-like pain, difficulty of grabbing an object, stinging, prickling, thrilling sensation, difficulties to evaluate whether it is hot or cold, and the lack of strength. These are areas of concern. If any of these are unchecked, plus a risk factor, then you can really strongly recommend your patient that there is a need for you to be diagnosed by the doctor, to be checked by the doctor, because you are showing early signs possibly of peripheral neuropathy. And I would like to emphasize again, the only way that we can go around this one and help our patients is to help them identify it early so that it does not progress into something that we can no longer address or help them with. So thank you so much. I hope there was knowledge there that was gained, especially for our pharmacists in the community. This is Dr. Kenny James Merin, and that's how you put life back in your patient's hand. But of course, before I formally end, I would like to ask a question. I will launch a poll. Ayan. How do you usually find out patients' diabetic peripheral neuropathy symptoms like tingling, numbness, burning sensation? Is it letter A, patient voluntarily complains about the symptoms? Is it letter B, I usually proactively check diabetes patients on these symptoms? Is it letter C, I find out during patients' regular foot checking, or others? All right, I'm going to give around 30 seconds more for us to answer. Let us know what you think. All right, ending the poll in 3, 2, 1. All right. Most of us answered letter A. Of course, that's also right because when we do counseling, when patients mention these symptoms, plus you know that there's a risk factor, that is one way of really finding out if they have peripheral neuropathy. But letter B is also a good answer, where you proactively check patients on these symptoms. Even letter C, we can actually, if we really specialize on diabetes health, then regular food checking is something that we encourage to our patients and something that we can train them to do. And if there are any symptoms of peripheral neuropathy, then it is an opportunity for pharmacists to do interprofessional collaboration with our physicians. Thank you so much for your kind attention. And again, I thank you for taking time this Saturday to learn with us. Thank you so much. Mikey?
All right. Thank you very much, Dr. Kenny, for explaining the roles of pharmacists in screening patients with peripheral neuropathy. It brings me back to the clinical roles of pharmacists, not just in the hospital, but also in the community. And I believe that community pharmacists have a major role in managing and preventing the advancement of peripheral neuropathy. And once again, I would like to thank all the participants who answered our poll or our second poll for the webinar. So I know you're excited to meet our third speaker, so let me just introduce him. He is a Malaysian medical doctor specializing in endocrinology, a fellow and member of the Royal College of Physicians in Edinburgh. He completed his subspecialty training in endocrinology from the Malaysian Ministry of Health, and he's currently a consultant endocrinologist at Sunway Medical Center since 2019, and formerly the Associate of the Faculty of Medicine in University of Malaya from 2015 to 2019. He is also a clinical researcher, publishing numerous articles that focuses on diabetes management and endocrinology and are recognized locally and internationally. He also provides lectures and chairmanship to local, national, and international conferences and public health forums. He is awarded for his excellent service by the University of Malaya in 2017. Let us all welcome and give our virtual round of applause to Dr. Alexander Tan. Take it away, Doc.
Okay, thank you very much, Mikey Mendoza, for the very kind introduction. Now, I think PNG has asked me to start with a poll, actually. So I hope on your screens you're able to see poll question number 3. On a scale of 1 to 10, what is your awareness of the role of B vitamins for the management of diabetic peripheral neuropathy? 1 is not aware, 10 is very much aware. Please answer. Or should I launch the poll again? Can you guys see the poll?
I can see the poll on my end, Doc.
Yeah, okay. So on a scale of 1 to 10, what is your estimated awareness of the role of B vitamins? No answers coming through. Should I share the poll again? I'll try sharing the poll again. Wait, hang on. Question 3. Yeah, sorry. Can you answer again? I do apologize. Has the poll ended?
Yes, it ended on my end. So
yeah. Okay. So hang on. So maybe I'm not quite sure how to reset the poll. Okay, so share results and go to question number 3. Relaunch poll. Okay, I'm relaunching the poll. I do apologize to all of you for the glitch. And the results are coming through. We have some 10s. So more than half of you have responded, 60%, more than that. Okay, very low numbers who sort of say that they're not aware. And I think it gradually increases, but in fact, the majority are saying 10 out of 10. Many of you are, top answer is 10 out of 10. Many of you are very aware. So I think if many of you are very aware, that's it. I don't need to give my lecture. Okay, no, just kidding. Okay, I think that's pretty good. 69% of you have participated. And I think as you can see, the results, the highest number is 23%. Of you all give a rating of 10 out of 10. Now, of course, there are some of you who sort of are aware, somewhere in the middle, a little bit more than the middle. But yeah, I mean, this is pretty good results, I think, for P&G Health. Everyone knows about neurobiome. I'm going to end the poll here. Okay. Yeah. So when it comes to the management of peripheral neuropathy, you might be asking this exact question: why am I going to be giving B vitamins? Okay. Now, of course, guidelines do recommend and state that medications are the treatment recommendations for neuropathic pain. Neuropathic pain is one of the most difficult conditions to treat. Pain is not easy in itself because it's extremely subjective, right? There's nothing to sort of say that, oh, I've given you this medication, your blood pressure is better, your glucose is better, your cholesterol is better. But pain, you treat it, it's the patient who tells you back. And you can actually see that in terms of the first line, you are going to be familiar, tricyclic antidepressants, such as amitriptyline, SNRIs, such as duloxetine, etc., gabapentinoids, or in fact, topicals if it's a focal peripheral neuropathy. Okay, if that's not enough, usually you would actually increase the dosage, either the dosage or increase the number of therapies that you give, combining them, or in fact, you start with opioid type analgesics. You then can, of course, move on to third line. There are even interventional therapies, right? There are basically devices can be worn or implanted, okay, to reduce the substance P activation, i.e. the pain sensation. That moves on to neuromodulation. Then you can in fact go on to low dose opioids, right? Fentanyl, morphine, etc. So again, difficult things to treat. When you reach things like the third, fourth, fifth, and sixth line, typically you would be not seeing a normal physician, you'd be seeing a pain specialist already. Now, at the end of the day, when you talk about a disease like type 2 diabetes, you've already heard from the earlier speakers that, you know, it's not just one single disease, right? Of course, we're talking today about peripheral neuropathy, and peripheral neuropathy can come from other things as well, such as alcoholism, autoimmune disease, CIDP. But when it's a disease like type 2 diabetes, which strikes multiple organs, right? It strikes your heart, it strikes your eyes, it strikes your brain, it strikes your kidney, okay? Because if it starts striking your kidney and you start to develop renal impairment, you know, it's going hand in hand. Poor glucose control, guess what? Your patient develops peripheral neuropathy. Poor glucose control, he also develops renal impairment as well. Once you have this, right, all of you are pharmacists will know there needs to be a dosage adjustment for renal impairment. And in fact, for your SNRIs, right, for example, your duloxetine, etc., you will have issues prescribing it in these patients who have renal impairment. Now, at the same time, don't forget, there is, Dr. Navin did state earlier on, that is this autonomic neuropathy, okay, which can also occur in addition to the peripheral neuropathy. So peripheral neuropathy, it's your toes, it's your feet, and if it gets severe enough, it's your fingers. Autonomic neuropathy can affect your bladder. And what is one of the common side effects of tricyclics? Urinary retention. So if you already have a patient who has urinary retention because of autonomic neuropathy from the diabetes, then you give them a tricyclic, right? You will make things, in fact, even worse. Now, topicals for focal neuropathic pain, sometimes these are capsaicin-based and they can actually make it worse for your patients as well. Many of our patients are also elderly, and so therefore combining multiple different analgesics, neuropathic analgesics like gabapentin together with an SNRI can cause significant side effects. Many of them are intolerant because it causes them to be overtly sleepy, excessively sleepy, and many of them also cannot tolerate it because it can cause dizziness, etc. So again, there are these limitations and downsides when it comes to pain control, and sometimes it's a matter of juggling it, dose adjusting it, and finding the correct agent which can effectively treat the symptoms, but at the same time don't cause side effects. Now, when it comes to the treatment of neuropathy, of course, yes, the painful neuropathies, you have to provide symptomatic treatment. You also have to, of course, treat the cause, whether it's due to glucose or due to an infection or due to alcohol, etc. You have to treat the underlying cause. And then, of course, there's also the mechanism-based treatment. So what I'm actually going to try to talk to you about here is, yes, symptomatic treatment, all the analgesics, okay, you have all these options available to you. You have to treat the cause as well, because if you think about it, you have a nerve. This nerve is under damage, right? It's being burnt by, let's say, diabetes, or it could be being burnt by alcohol, or being burnt by a neurotoxic agent, right? Like say ethambutol, okay? You have to treat the cause, because if you don't treat the cause, right, the fire continues to rage, the damage continues to go on. Your patient is hyperglycemic, the glucose is high, okay? You can keep giving symptomatic treatment, but it keeps burning, right? Burning, yes, the symptom, but your nerve keeps on getting damaged, okay? Now, one thing important to realize about your peripheral nervous system, which is different from the central nervous system, is that there is a great ability of your peripheral nervous system to regenerate. And this is the difference, okay? Patients in their central nervous system, if they have a stroke, if they have some form of lesion which has affected it, regeneration is very difficult. But your peripheral nervous system is different. Your arms, your feet, they undergo stress and strains 24/7, right? When you're walking, when you're pushing your arms against a door, okay, when you're hanging from a monkey bar, this stresses and strains your peripheral nervous system. And guess what? It can regenerate. If you sit on an airplane for too long and you start getting pins and needles and you get up and you stroll, okay, and you walk, right, that is an example of regeneration in a way occurring. Of course, it cannot regenerate if it's completely 100% damaged, right? There is no regeneration if you completely cut off my toe, right? There are no more nerves, there's no more toe. Okay, and similarly, if the diabetes is very advanced, if the degree of nerve damage is very advanced, then you're not going to be able to get regeneration. Now, it's very important, therefore, if you have a system which can regenerate, that you flood this system with enough tools, right? One of which, of course, is your B vitamins to help it to regenerate. So again, remember, keep this in mind. Yeah, symptomatic treatment, always very important. Your patient is suffering, alleviate the symptoms. But at the same time, you need to treat the cause. Whatever is causing the damage, you need to try to reduce or stop. And you also need to try to aid the repair. Okay, you stop whatever is damaging it, but the damage is already there. If it can be repaired, you want to provide an internal milieu, or you want to provide a situation, right, or where the repair is optimized, and that's where the B vitamins come in. Now, you'll be aware, of course, that you have 8 different B vitamins, but specifically B1, B6, and B12 are your neurotropic B vitamins. And you can see the roles of the neurotropic B vitamins. They have antioxidant roles. They have roles in terms of the formation of the myelin sheath. They have a role, of course, in producing neurotransmitters as well. And you can see that with B12, there's actually a role with myelin regeneration, okay? Now, when it comes to these B vitamins for neuropathy, what you can actually see is with B1, definitely this isn't just in the nervous system, but it's all across the board for our entire body. It does help with mitochondrial function. Okay, and you remember that mitochondria obviously is the energy supplier for many cells in your body. Now you can see with B6, it's a key element in neurotransmitter synthesis, and of course with B12, it does promote nerve regeneration and myelin sheath resynthesis. Now, what you want to do is you want to, as I said before, right? You want to stop the damage from occurring. So treat the diabetes, bring the glucose down. You want to give them symptomatic relief in the meantime. But at the same time, you want to optimize the conditions for nerve repair to occur. And for this to occur, it's better to give these neurotropic B vitamins in combination. Okay. Now they have a synergistic effect working together. So if you let somebody say with just B6, all right, yes, fine, it does have an element to play with your neurotransmitter formation, but if they are still not flooded or not having enough B1 and B12, right, then yeah, you do not completely provide an environment for your nerve protection and your nerve regeneration to actually occur. So of course, NeuroBeyond provides B1, B6, and B12 all together. Now, it's important to make a distinction between what is recommended daily allowances versus therapeutic dosages. Okay, there is a difference between these two. So for example, if you have a patient who, okay, what is a normal level for, let's say, cortisol in your body? It's a steroid, okay? There are physiological doses of steroids. Everyone has steroids in their body, okay? And there are also, of course, pharmacological doses of steroids. Steroids that provide an anti-inflammatory effect, all right? Steroids that provide an analgesic effect. And so it's the same thing when it comes to B vitamin deficiency, peripheral neuropathy treatments. You have to provide a therapeutic dose. Now, when you look at your RDA, your patient may say, oh, but you know, the recommended daily allowance for the Malaysian Ministry of Health is to say vitamin B1, 1.2 milligram, B6, 1.3, and B12, 2.4 micrograms. And I can get that from an adequate diet. Now, that's different from a therapeutic dose. You can see that for a therapeutic dose, you need much, much higher doses. You're trying to treat a medical condition. You're not trying to maintain health. You're trying to treat a medical condition and bring this person from an unhealthy condition back to a healthy condition. So, of course, NeuroBion is available in 100 milligram B1, 200 milligram B6, and 200 microgram B12. There is, of course, in some countries, NeuroBion Forte, which is 100 B1, 100 B6, and 5,000 microgram B12. And of course, there's also a parenteral version of this as well. Now, take note, of course, diabetes is not the only thing that can cause this. Quite frequently, my patients not my patients, but my colleagues who treat gastrointestinal conditions, right, liver diseases, they sometimes do see patients who are alcoholic, and alcoholics have a thiamine deficiency. Okay, they can develop subacute combined degeneration of the spinal cord. They can also develop something called Wernicke-Korsakoff syndrome. And again, the treatment of these is with high dosage parenteral vitamins. So again, right, there is a differentiation between what is recommended for just maintenance of health versus what is recommended for therapy, i.e. trying to bring somebody who's sick back to health. Okay. Now, you have to say, okay, well, that's all the various sort of pathophysiology and how the mechanism of action works, but does it actually work? Now, there are some studies, not many, and I'll show you some of them. This is an open labeled single arm trial, okay, where subjects with peripheral neuropathy from different etiologies, you can see here, some of it is carpal tunnel, some of it is diabetes, some of it is just idiopathic, some it's a combination, were given NeuroBion, neurotropic B vitamins, B1, B6, B12, over a 14-week period. And you can see that across all etiologies, whether it's diabetes or carpal tunnel syndrome, by the end of the trial, there was a reduction in their symptoms, right? This is what you want to see. This is what your patient wants. Okay, at the end of the day, he's suffering in pain, right? and you want to alleviate this, you want to treat this. How do you treat this? Yes, you do give them symptomatic treatment. Yes, you do try your best to reduce whatever it is which is causing it in the first place. And of course, as I said before, you want to make sure that their repair, right, is optimized. What the tools they are that need for, what the ingredients they need to repair their nerves is, of course, optimized. Now, of course, peripheral neuropathy in different individuals has different manifestations. Some of them say that it's burning pain. Some of them say that it's numbness, dysesthesia, paresthesia, allodynia, etc. But you can see that across the board, you get reductions in these various symptomatologies with neurotropic B vitamins. Now, that was a kind of single arm study. Well, is there a clinical trial in which it was a placebo-controlled head-to-head study? There is, not in as many patients, only in 30 patients, but you can see here that this is head-to-head placebo versus treatment group with neurobion doses 3 times a day, TDS. You can see that 40% of these patients had improvement in their painful peripheral neuropathy symptoms, particularly in their feet and legs. Now, again, this is a non-controlled clinical study with higher number of patients, 310 patients. And you can see that quite many of these patients, 87.4% of these patients with diabetic peripheral neuropathy showed symptom relief. Okay, so now if you take all this data together, definitely this is a positive signal for the use of neurotropic B vitamins, i.e. neurobion, for pain relief in peripheral neuropathy. This is a slightly different scientific study. These are nerve biopsies which have been, these are nerve biopsies looking at nerves which have been stained. And you can see that under conditions where they depleted B1, B6, and B12, you can see for yourself in these pictures that these nerve cells actually are degenerative. They are degenerating. But once they've been supplemented, you can see definitely they look a lot more healthier. There are a lot more connections. And in terms of their length and their viability, it's also improved. So then you ask, well, what, I feel a bit afraid because the RDA is only 1 something milligram, but here I'm giving, doses of up to 200 milligrams. Is this safe? And long-term studies have been done and basically generally very well tolerated. Of course, you don't want to overdose. So definitely for B6, you don't go to more than 500 milligrams per day. And again, right, once you have achievement of replete levels and your nerve repair is optimized, you do perhaps want to consider down titrating. Now, again, 1,000 micrograms a day of vitamin B12. Vitamin B12 is not just for nervous function, but also for your bone marrow to produce red blood cells, white blood cells, etc. So again, 1,000 micrograms has been shown to be optimal. There are no side effects with high doses of vitamin B12 for up to 7 years. Now, B1, sometimes there is parenteral administration, thiamine, for example, for, as I said, alcohol toxicity, patients who have chronic alcoholism. However, the parenteral administration is only associated with phlebitis. Phlebitis basically from the peripheral venous line, which is inserted. Sometimes hypersensitivity reactions, not of course to B1 itself, because everyone has B1 in them, but usually to an agent which is used for the so that the product is viable, can be stored, etc. So again, if you follow dosing recommendations, right, they are advantageous for the management of PN, right? To all my Malaysian pharmacists, next week we have to go and vote. And I just want to clarify, PN doesn't stand for Perikatan Nasional in this lecture. It stands for peripheral neuropathy. Your B vitamins levels can actually also be monitored, right? So if they are in deficiencies, you do have to be a bit more aggressive. And then once you bring them to normal levels, again, what is normal level for just normal maintenance function is different from levels which are required for neurotropism, i.e. Regeneration of nerves. So with that, I want to thank you very much for your kind attention. And I will stop my screen share and hand the time back to Mikey Mendoza.
All right. Thank you very much, Dr. Alex, for sharing the management of peripheral neuropathy. It is good to know that most of our B vitamins are over the counter and easily accessible. But of course, I'm speaking from a Filipino perspective. No, and of course, pharmacists can be a guiding hand to patients currently suffering from peripheral neuropathy. So, now that we learned so much from our lectures, let us put those information into application, okay? So we have two cases that is to be presented to our lecturers. So for our first case study number 1, the importance of early screening of peripheral neuropathy. So I'll just read the demographics and I'll invite one of our lecturers. So we have here a 47-year-old male public transport driver diagnosed with type 2 diabetes and currently on metformin and glimepiride for 12 years. So may we invite Dr. Kenny to share your thoughts about this case.
Hello, thank you so much, Mikey. Ayan. So we have a patient here, male, 47, public transport driver, as mentioned by Mikey. There is risk factors. You can see type 2 diabetes mellitus, and there is the metformin and glimepiride for 12 years. We mentioned earlier that the use of metformin at around more than 18 months will already increase the risk of developing peripheral neuropathy up to 2 to 3 times. So now you see that, hi, I would like to fill my metformin prescription. So the pharmacist, hi, Mr. Tan, it's very good for pharmacists to personally know our clients. How have you been? Of course, our small talk. Are you on the night shift today? Yes, I'm okay. Just having some strange feeling in both feet lately. There, that's a checklist already, because there is diabetes mellitus, there is long-term use of metformin. Now, the patient is now sharing with you that they are experiencing a strange feeling, both feet. So it is symmetrical and it's on the feet. It's common in the extremities, right? So now the pharmacist is thinking, Mr. Tan is diabetic, has been using metformin for more than 12 years. He is at high risk for peripheral neuropathy. So what should pharmacists do? We should screen, quick screening. Mr. Tan, metformin may cause you to develop a nervous system disease called peripheral neuropathy. May I ask a few questions and run some quick tests just to check? Mr. Tan, you mentioned feeling like there are ants crawling in your feet. So we are now using the descriptors so that our clients can better relate. With your reduced touch sensitivity, maybe the pharmacist already checked, no, with the feather, with the wool, with the toothpick, or with the pin. I would recommend you B vitamins for nerve protection. So of course, it's over the counter. Pharmacists can recommend as soon as we can see in the screening that the patient is at higher risk, then the sooner they start with the B vitamins, the better. But however, we should never forget, meanwhile, you might also want to consult with your doctor for further testing. In conclusion to this one, PN could be highly dangerous and devastating for diabetic patients, especially in the driving profession. Imagine if you're driving and your feet is having that burning sensation. That would be difficult for you and even dangerous, right? This case report highlights the need for PN screening among diabetic patients, especially those that are using drugs that may also induce peripheral neuropathy, especially public transport drivers, to prevent serious traffic accidents. Yeah. So I hope you were able to apply what we have learned earlier, especially on the screening of our peripheral neuropathy. Mikey?
All right. Thank you very much, Dr. Kenny. No, I do agree with that saying, kasi that is very common. This case is very common in the community practice. So I hope our participants gain some insight on how to screen patients when it comes to peripheral neuropathy. So thank you very much, Dr. Kenny. So let's proceed to our second case. But before anything else, may I remind everyone that questions will be answered right after this portion. So I know you're very excited. So I'll just read again the second case. So the importance of screening for peripheral neuropathy in the elderly. So we have here a 65-year-old female and is a vegetarian and smoker. So please share your thoughts about this case, Dr. Navin.
Thank you. We are going to the second case. So this is actually your female, 65 years old female. She is a vegetarian. She is a smoker, right? So unlike the previous case was about a patient on metformin, yeah. So this is about someone who is vegetarian. So if this patient comes to the counter and says, for example, "Hi, I would like to get some of my usual vitamin C and D supplements." So what are the potential things that you can ask the patient is you can say, because if it's a regular customer, of course, you can notice the patient, right? So you can say, "Hi, Madam Lee, I notice your walking is slightly wobbly. Are you feeling okay?" So let's say the patient says that, other than feeling dizzy, sometimes I'm okay. All right. So what happened is you can ask the lady, "Madam Lee, what is your diet like? Do you smoke or drink alcohol?" So you're trying to actually get a little bit more information about the patient's lifestyle here, also the diet. All right. So then she says that she's a vegetarian and she smokes, right? And she think that she is healthy. Okay. What are the things that you actually spot here? Okay, now it's about diet. Earlier it was about metformin. Metformin causes B12 deficiency. Here, a patient who is a vegetarian, it is actually quite hard for them to actually get enough amount of vitamin B12. So because B12, I think to get B12 from a vegetarian diet is actually quite difficult. So so this is also one of the risk factor, right? We've been talking today. So you can see that with the vegetarian diet, and you are also a smoker. And also remember the age. Just now we were saying that is as the age increases, now she is in elderly group, like 65 years old. Definitely she has higher risk of developing this peripheral neuropathy. So you have three factors here: vegetarian diet, smoking, and also elderly age. So you can prompt the patient. You can say that, "Can I ask a couple of questions and run some quick tests to check whether you have peripheral neuropathy? If you're at risk of having peripheral neuropathy, then we can do something about it." Yeah. And let's say the patient cooperates, and then let's say you from your assessment you found that patient's touch sensation is not as sensitive. So you can actually recommend B vitamins for nerve protection. Yeah, you don't wait. Why I'm saying that is that, remember, my earlier presentation of shared that, even a patient who is pre-diabetic or even at an early stage, they are already, probably having the nerve damage. Okay, so we don't want this to progress. Let's say now she's 65. If let's say she lives up to 80 or 85, then she is going to live with that, problem, and it's going to affect the quality of life, and during her golden years, right? So you recommend B vitamins for these patients, and tell the patient while taking this B vitamins if she might want to consult the doctor if she feels of these symptoms of neuropathy, like tingling. You can actually describe. We cannot use this jargons, this medical jargons to the patient. They might not understand. You can describe it something like if you feel like some ants crawling on your feet, or like sudden electric shock and all that, these are triggers that you should actually go to your doctor and actually for a checkup and see that if you need treatment. Yeah, so you can actually what you're doing is actually you are preventing this peripheral neuropathy from getting worse. At the same time, you're also warning this lady to actually seek help, medical help, if let's say the condition worsens. Of course, again, to recap, more than 30% of elderly patients aged more than 65 years experience fall at least once a year. Okay, this is also one of the issues with elderly people. You know, we are very worried of fall, you know, which is also associated with mortality. So, you know, how this can be worsened by peripheral neuropathy is that sensory deprivations due to peripheral neuropathy add to the risk of falling and impact patients' general and mental well-being. So we want in this golden years for patients to actually feel comfortable, good quality of life, and live very comfortably for as long as they live. Yeah. So with that, I mean, I think you've got from these two cases how to actually effectively do prevention and also, you know, direct the patient to the doctors, you know, when they need to seek help. Yeah. So let me just proceed further. Yeah. Mr. Mikey, Mr. Mendoza, I'm going to the next slide, right? Summary.
Yes, yes. I'm sharing the summary slide already.
Okay, you are sharing it. Yeah.
Yes, yes, yes.
Okay. So, what we would like to stress from today's webinar, we have participants from Malaysia and Philippines. All of you are pharmacists. So early diagnosis and timely management of peripheral neuropathy is very important because peripheral neuropathy is a debilitating condition affecting the nervous system. And we know from today's lectures that the elderly and diabetic are particularly at higher risk of peripheral neuropathy compared to other people. So these are the people to look out for, to actually, you know, for you to actively perform screening. Yeah. The importance of screening for early identification of peripheral neuropathy is very important because I think earlier Dr. Alex have also mentioned that nerve regeneration is possible before 50% of the nerves are damaged. So it's very important to act early. So do not underestimate the importance of supplementing this B vitamins early in your patients. Yeah, and also we need to identify the possible causes. Now that you've known that actually, you know, patients, diabetic patients, and especially those on metformin, you know, can cause a B12 deficiency, and that can lead to peripheral neuropathy. Even the disease itself, metformin, is also possible. So all this should play in your mind, you know, when you're actually looking at these patients who come to your pharmacy, right? And the therapeutic doses of nootropic B vitamins B1, 6, and 12 is beneficial for nerve protection and also pain relief and peripheral neuropathy. And to summarize, you can help patients identify peripheral neuropathy early via these 5 steps. Okay, so you firstly classify the symptoms based on the duration of onset, and then you do a careful medical history and you assess the signs and symptoms proactively. That means you ask, you already know these symptoms. You can ask if the patients have these symptoms, and you use simple tools to test for nerve protection. Okay, as mentioned by Dr. Merin just now, and also finally, after your assessment, you know what you're going to do. You're very clear. You can advise the patient to seek a consultation with a physician if, let's say, you feel that this patient really need to be referred to a doctor, right? So identifying high patients at risk of peripheral neuropathy and recommending nootropic B vitamins 1, 6, and 12 for long-term nerve care is very important and can be done effectively by pharmacists in your setting, yeah, in community pharmacy as well as in the hospitals. Yeah. With that, I also would like to end by actually saying, you know, what are the things that you potentially can do for patients if, let's say, they come with these scenarios, like, for example, you can identify potential risk of peripheral neuropathy in patients and refer them to physicians for follow-up. You know, how do you trigger that that conversation? You can tell patients like your feelings like there are some ants crawling in your feet or sudden electric shock are signs of peripheral neuropathy. So you may want to consult your family doctor for further examination. So you're putting that in the patient's head, right? So because sometimes patients do not immediately just follow your advice, but you have to impart that knowledge, or you have to pass that information to them. Otherwise, they do not know what's that feeling of and scrolling, that tingling sensation. They probably just live with it for years. So you have to give that information for them so that they can actually know what to do. So early identification of patients at high risk of peripheral neuropathy, and be familiar with ways to proactively prevent peripheral neuropathy symptom onset. So we have learned today about peripheral neuropathy. So how do we help? So at the early stage itself, we can really intervene, really help patients. Yeah. So by saying, like, it is well known that vitamin C supports healthy immune system, whereas vitamin D and calcium are good for bone health. B vitamins like B1, 6, and 12 support a healthy nervous system and protect your nerves. Okay, so this is what you tell the patients, because I'm not sure about Philippines, but in Malaysia, a lot of our patients associate vitamin B complex with energy boosting, or general well-being. If you ask many of the people, they do not know that you can use vitamin B for nerve health. Okay, so to protect nerves. Okay, generally they associate it with energy boost or general well-being. Yeah, so it is important to actually tell patients this. And you also, address holistic and long-term management of peripheral neuropathy, especially for patients with diabetes and elderly with polypharmacy. This is, of course, from today, elderly patients, elderly is a group that you really can target on or focus to give your pharmacist care, especially if it's a diabetes patients on metformin. You can tell the patient that metformin over the years can cause peripheral neuropathy, due to depletion of B12 vitamins. So this can cause the nerves to be damaged. We want to catch it early when nerves can still be repaired. Can I ask you a few questions to check? Yeah, so then the patients, of course, if they're concerned about their health, they will actually cooperate with you, so that they probably will answer all those questions, and you will know what to do with the patients. You can actually recommend them the supplements, and or probably refer to the doctor if it's due, right? And lastly, timely counseling and appropriate product recommendations for patients with early PN symptoms. Something like, you can tell the patients, most people are familiar with benefits of B vitamins and energy levels and brain function, but they are also essential for nerve health. The neurotropic B vitamins, B1, 6, and 12 work in synergy to repair damaged nerves and protect the nervous system. So this is something that you can tell the patients, because you have patients coming to the pharmacy, looking at the shelves and looking at different types of vitamins, multivitamins, or vitamins or minerals or trace elements. Sometimes they do not know what to choose. So by practicing as a community pharmacist, you can really ask them these questions. They actually guide you to actually recommend the real vitamins that they really need based on their condition. Yeah. So with that, I actually pass back the floor to Mr. Mendoza.
Thank you very much, Dr. Navin, for sharing your thoughts of the case and providing synthesis to the lectures for this day. All right, I know everyone is very excited to proceed with our Q&A session, and I'll do my best, hopefully, to answer all questions in the Q&A section. So let's start. So may I invite all of our lecturers, Dr. Kenny, Dr. Alex, and Dr. Navin, for our Q&A session. All right, so here's the first question. So I guess this would be directed to Dr. Alex. So how can an increase in blood glucose damage the myelin sheath when it's mostly made up of fat and proteins?
Yeah, glucose is toxic, right? Hyperglycemia is toxic, and there are many pathways in which you can damage anything, right? So it doesn't matter whether it's made out of fat and protein, glycoproteins, lipid cell membranes, etc., can be damaged. So it's really not we don't exactly know what is the pathophysiology behind peripheral neuropathy, but there are two general theories. The first is, of course, neurovascular damage. So in the same way you heard that Dr. Navin said that there is microvasculature. So everything which is living in you, everything which has a cell does require blood supply. Okay, so if you have microvascular damage, right, damage not in the larger vessels, but in the smaller blood vessels, then yes, you will have not just myelin damage, but also axonal damage as well. The thing which the myelin is covering, the axons, can be directly damaged through that. The second, of course, is hyperglycemia induces the formation of stuff that's not supposed to be formed. Polyol, sorbitol, glyol, all this kind of alls, right? They are these reactive oxygen species, and they are actually also directly toxic to different cells. So I hope that answers your question. We're not quite sure which one it is, whether it's neurovascular or whether it's a metabolic damage pathway, or probably it's a mixture of both. But yeah, it doesn't matter whether it's just lipids, phospholipids and glycoproteins, they can be damaged by diabetes.
All right. Thank you very much, Dr. Alex. Any input from our two lecturers, Dr. Kenny and Dr. Navin? So do you have any additional inputs to what
I think
Dr.
that's
Alex
very
has mentioned?
clear.
All right.
Dr.
Thank you
Asad.
very much. Okay,
Yeah,
so
I think that's very clear also, but there are also something that I have read before, that diabetes can also act on our expressions of the gene, which can also affect the formation of our myelin sheath. So in general, I agree with Dr. Tan where there is no clear line yet. However, there are theories that are very much widely accepted for us to understand that this can really damage.
all right. Thank you very much for the additional input, Dr. Kenny. So we have another question here. I guess this is directed to Dr. Navin. Hello, am I correct to say that peripheral nerve damage can happen to anyone with advanced age? Is vitamin B complex supplementation mitigate the symptoms of peripheral nerve damage?
Yes, I think the answer is correct, because even from the presentation just now, you need not have diabetes to have peripheral neuropathy, because having being older age, okay, elderly, is already a risk factor for having peripheral neuropathy, because it's age related, and not necessarily that the patient must be diabetic, right? But of course, if you have diabetic, as what Dr. Alex has also mentioned, there's a lot of damage that happens due to the persistent hyperglycemia, because the glucose is toxic as well, right? It can cause a lot of inflammatory markers to be formed. Okay, so so elderly itself is a risk factor, and of course, supplementing early, it's very important. I feel that a lot of our patients, I'm not very sure whether in Philippines it's the same thing. We need to pay attention to this, because as I mentioned before, this complications probably doesn't ring a bell, because probably it's not like visually look as severe like the cardiac complications or the renal complications, but then these really affects the patient's quality of life. In one end, you want to prolong the patient's life, you want to prevent mortality, and you have tight control and all that, but the other end, we also must ensure that they have good quality of life. What is the point if, let's say, they live long and then they actually they really can't sleep, or they have mood problems with all these peripheral neuropathy causing them to have that. Yeah, so this is something that we can effectively do by supplementing early. Of course, not all patients, or not all people who come to your pharmacy, you will actually recommend B12 or B1, 6 and 12 combination neurobiome, but then you already now know how to stratify the risk and how to choose patients who you want to intervene early. And diabetes is definitely one of them who really need early supplementations, partly because not only the disease, but because we know that for type 2 diabetes, most patients will be started on metformin. Metformin is something that's cheap and very efficacious and will be used throughout, I think, even if the patient goes on to insulin up until the level that their EGFR is probably less than 30, and with renal impairment that will stop. But generally metformin is there for, if the patient is a long-standing diabetic for 20 or 30 years, it will be there. So so in parallel to that, I think supplementing this B12 should be considered early. And we need to pick this up. We need to screen, also asking, you can ask the patient, how long have you been diabetic? So if it's 10 years or something, and they are not on a supplementation yet, then really rings a bell. You really need to intervene. So yeah, hope that answers the question.
All right. Thank you very much, Dr. Navin, for a very clear explanation to the question given. All right. So we'll try to accommodate more questions, but this question is, I think, directed to Dr. Kenny. Wait, let me just read. Okay. Ayun. My mom is disabled. She has hemiparalysis on the left. Is her left side still at risk to have peripheral neuropathy? Also, how can I use the screening test, such as using cotton toothpick on that side?
Thank you for that question, Mikey. Well, definitely there has already been damage on that side because of, maybe, I'm guessing, their stroke. But you have to focus on the better side, where these symptoms are not yet manifesting. But of course, if those symptoms are present on the other side, that would be a good indication that there is it's a probable good choice to start on B complex vitamin for that patient.
I see. So thank you very much, Dr. Kenny. So I guess we can only entertain one question, and this one is, I think, for everyone. Okay. So we have here a question. A friend is under metformin 500 2 times a day for more than 15 years and B complex supplement once a day. However, he still experienced symptoms of peripheral neuropathy. Can you recommend other means or management to relieve the symptoms? So I guess we could start back to Dr. Alex. Do you have any recommendation or other means of management to the question?
Yeah, so I think it comes back to understanding what the pathophysiology is going on, right? So first of all, if you have metformin on board, there's going to be B12, long-standing metformin on board, there's going to be malabsorption of B12. And so therefore you do need to make sure that that is supplemented, and in fact beyond supplemented, given a therapeutic dose. The second thing is, of course, your house is on fire, right? If you have hyperglycemia which is uncontrolled, right, it might be possible that the doctor's going to increase the medications, including metformin, to try to bring the glucose under control. And so what that then does is that it tries to off the fire, right, not burn. But part of it has already been burnt, right? One part of the house has already been burnt, so you need to repair. And so when it comes to repair, your friend is already receiving BCO, whether or not it's at a therapeutic dose as recommended, or whether that's a sub-therapeutic dose. So you need to look exactly at your vitamin B co-formulation, what doses are being given, is it to a therapeutic kind of level. And then, of course, at the end of the day, you have a patient right in front of you, regardless of the fact of you are thinking theoretically about what's going on in his neurons. You have to treat his symptoms, right? So if you need to cover these three facets to managing this person's neuropathic pain, right? You have to treat the pain. Definitely, you have to give an analgesic of some sort, which works. You have to make sure that the repair mechanisms, you give your worker who's repairing the correct and enough tools and bricks, etc., to build back whatever has been damaged, and you stop what is causing the damage in the first place, or you reduce to the best of your ability.
All right, thank you, Dr. Alex. So, sorry, before I proceed to the next lecture, so we have here a very interesting question from one of our participants. So, mostly of my immediate family members are diabetic. I do annual checkup. And she doesn't have diabetes, thank God. And her question is, can she take vitamin B complex for prevention? So I think Dr. Navin can answer next for this question.
Yeah, I think, of course, there's nothing is stopping her from taking supplementation, of course. I think, if, of course, as clinician, Dr. Alex also say that if you really can get it from your diet, I think, of course, that's recommended, of course. But I think with our lifestyle, and I don't know whether patients, our people nowadays get really a well-balanced diet every day in all their meals. So that's also something to look at. And of course, you can supplement early. So there's nothing wrong. But of course, the doses of, like from the presentation just now, right? You don't need a very high dose, for example, if you say you are not really a peripheral neuropathy patients, but you just can take a general dose for supplementation, and later on only up titrate the dose based on whether you have peripheral neuropathy or it worsens and so on. But I think supplementing is important, because if you remember from my slides just now, even at a pre-diabetic stage, a patient who's not diabetic, there's the nerve damage can already occur. So these complications usually not only the neuropathy. If you look at other complications, a lot of times, there's one big study called UKPDS. You can see that at the point of the trial, I think before diagnosis, right, a lot of them already started having that complications. So nothing is stopping them from supplementing. Yeah.
I see. Thank you very much, Dr. Navin. Do you have any additional input, Dr. Kenny?
Well, I definitely agree to that. There's nothing stopping them from taking the supplementation. However, there are conflicting results if whether it can help or not. But it was mentioned that nerve damage happens way before we can even detect that there is diabetes. So if you look at it, if it's on the safe dose side, then it might probably be best to look into supplementation. Also, I'd like to add, Mike, there is, in relation to the question that was asked to Dr. Alex earlier, we can also recommend on reviewing what type of vitamin B12 we are using. There are two types, the synthetic and the naturally occurring. There are studies that suggest that the synthetic one is better absorbed. However, the naturally occurring, our methylcobalamin, has better retention. So maybe when there is a recurrent pain, aside from the pain reliever, addressing the root cause, we can also shift into other types of B12 supplementation if it will help in the long run. I think we can consider the better retention. Maybe it can also help as part of the treatment regimen.
All right. Thank you very much, Dr. Kenny. Thank you for adding additional input. How about for the former question, Dr. Navin, do you have any additional inputs regarding the management?
No, I think it's very clear explained by Dr. Alex.
All right. So thank you very much to our panelists. So as much as I want to answer or to share, to ask the questions of our participants to the lectures, so we have limited time. So we will collect all the questions, and we will try to send it. We will send it to the lecturers, and they will be happy to answer it to you. And the answers will be directed on the Swipe RX app. Okay. So once again, let me thank our lecturers for today, Dr. Navin, Dr. Kenny, and Dr. Alex Tan for our lecture field afternoon. All right. Thank you very much.
Thank you.
All right. So I know some of you, our participants, are asking how to get their certificates, right? So as I've mentioned earlier, you need to attend the webinar for a minimum of 2 hours to get a certificate, because your time here is recorded, and answer the feedback form at the end of the webinar. Link is available on the chat box and the Swipe RX app, or you can scan this QR code flashed on your screen. All right, so there. Swipe RX will send you an email with a link and instructions on how to download your certificate once we receive the CPD approval from the Philippines, which is the PRC, and Malaysia, which is the MPS. Now, for any questions or concerns, please feel free to reach out to us at hello@swiperxapp.com. All right, so a knowledge-filled afternoon as we learned so much from our 3 speakers. Again, as part of our World Diabetes Day celebration, this webinar is provided by Procter & Gamble Health, International Diabetes Federation, and of course, Swipe RX. This has been Dr. Mikey Mendoza. See you on another webinar series provided by Swipe RX. Thank you very much.